The, so thanks for joining the meeting, sir. So on behalf of Sipla, we welcome you to the meeting, sir. So about Dr. Arun, so it's a DM Gastro, so consultant gastroenterologist and hepatologist in Apollo Hospital. So you have wash exposure. So today the topic is treatment in the management of ulcerative colitis and Crohn's disease. I hand over to you, doctor.
Thank you, Team Ziplo, give me an opportunity to be here. And I would like to see today in this wonderful evening, we are here to discuss about one of the most complex scenario, most complex entity in the field of gastroenterology is none other than inflammatory bowel disease. As you all know, inflammatory bowel disease means in case if the patient is going to land up with any evidence of chronic inflammation in your GI tract. So once a patient is going to evidence of chronic GI inflammation, it may be extending from your oral cavity till your anal canal starting from your oral cavity, your esophagus, your stomach, as well as your small intestine and large intestine. It can extend anywhere in any part. There are two major entities, the brief entities you are supposed to know. One is because of your ulcerative colitis, one is because of your Crohn's. Any chronic relapsing inflammatory condition which is happening is nothing but your inflammatory bowel disease. So what is the etiological trigger? It might be because of multiple sources. There is no single prominent etiological trigger being identified for this condition as of now. It could be autoimmune trigger, infected trigger, and your inflammatory cascade, which is going to get activated, and then this kind of events which is going to get progress. And once you're going to diagnose a patient with either your inflammatory bowel disease, either in the form of ulcerative colitis or Crohn's, in which we are going to look into the major key point of difference is how you're going to differentiate. So the most important entity, how are you going to clinically recognize this presentation? Briefly, I would like to take on my discussion with you all to analyze the base physicians and surgeons who are being into the field and the gastroenterologists who are in the initial phase of beginning. You should know all the pointers how to diagnose this kind of presentation. And diagnosing alone will not help you. And tackling the patient will in effective way and preventing the patient from major complications and serial follow-up on alleviation of anxiety, stress control. All these pointers is very, very important to address a patient with inflammatory bowel disease. So so far, the etiological trigger cannot be identified as idiopathic disorder in which the dysregulated immune response to your host intestinal bacteria being taken on. And two major entities, your UC as well as your Crohn's, and more than 80% of the population are currently diagnosed in second and third decades of life. But right from your pediatric population till your geriatric population, till any age group, from starting from the maximum preponderance from 10 to 20 years, and even from 60 to 70 years of age population, you may be getting this kind of events in which your inflammatory bowel disease to progress. Apart from that, so the most important thing is what does this ulcerative colitis? In case if your lesion is going to involve mainly in your large intestine, that means if the lesion will be predominantly restricted to large intestine, usually the patient will be having evidence of ulcerative colitis. Ulcerative colitis, the characteristic presentation will be the patient will be having pain, bleeding PR, bleeding per rectum. That's a characteristic presentation. It may be flank, blood, hematochezia may be there. Apart from that, the patient may have tenesmus, which means the urgency, the rectal involvement, that's very characteristic. And moreover, it will be predominantly involved in a large intestine, but doesn't mean the small intestine will not get involved. It's called backwash hiatus, in which even if the small intestine is going to get involved, but predominant area of restriction will be in your large intestine. Apart from that, your Crohn's disease will be predominantly restricted starting from your oral cavity till your anal canal. Anywhere in the GI tract, it will be involved. That is why Crohn's disease is very, very difficult diagnosis and very, very difficult entity to tackle. And moreover, the chronic relapsing remitting events and patient will be having multiple presentations, the stricturizing, fistulizing lesions that will be very characteristic population, characteristic in population of Crohn's. That's why tackling a Crohn's will be more complexity rather than tackling a patient with ulcerative colitis. So this is how we need to differentiate. Apart from that, the predominant area of involvement, as discussed, will be in large intestine, this will be in small intestine, and the transmural involvement will be a characteristic presentation of your, and apart from that, the stricture, the fistulizing, the penetrating lesions, all those things will be very characteristic of your Crohn's disease. And the findings, the anemia and complexity, the right-sided colonic pathology will be more common in case of your Crohn's, and left-sided colonic pathology will be more common in case of your ulcerative colitis. These are the basic outlines about the differentiating points. And usually The ulcerative colitis will be affecting only the inner layer of the bowel wall, but in Crohn's, it will be affecting all the layers of your bowel wall. So that's how the differentiating pointers has to be taken into account, and you are going to take into the discussion. So as I already discussed, the diarrhea will be the characteristic presentation with blood and mucus. Here, the abdominal pain will be predominantly a periumbilical location. And for example, if the patient is having small bowel Crohn's, and today also one doctor have been raised a question, how are you going to differentiate your inflammatory bowel disease when compared to your tuberculosis? That main pointer I would like to state here, because tuberculosis and Crohn's will always meet together. The patient may have evidence of entire colon lesion, maybe or the patient may have restricted lesion predominantly to your large intestine. I mean, to the right side of the colon, or the patient may have restricted lesion only to the cecum and ileal compound will be involved. So if the patient is having ileocecal involvement, only if the lesion is predominant to your ileocecal region, that might be very differentiating for you, very difficult for you to diagnose, to differentiate from your tuberculosis from your Crohn's. So how are you going to differentiate your histological? We're going to help you. The clinical presentation is supposed to be the, and moreover, the chronic disorder in case of Crohn's. But even then, if you're suspecting tuberculosis, your gene expired as well as your CBNAT, all those things, you are going to yield the diagnosis for your tuberculosis. But all the histopathology will not turn into a tuberculosis. And you need to look for your granulomatous changes in your Crohn's disease and all those things. Non-case eating granulomas may be there, and you need to look for your tuberculosis changes, your granulomas will be there in case if you're suspecting evidence of TB. Apart from that, so characteristic presentation has to be delineated. If you are having a suspicion, if you couldn't able to diagnose, what's the people of AIMS and other centers they used to do, they'll be initiating the treatment for your tuberculosis first for 1 to 2 months of intensive therapy, 2 HRZT they'll be initiating, and then they will serially follow if you cannot able to differentiate Crohn's from this kind of condition, even with your markers, if your inflammatory markers, if it is in the higher side, or ANCA, your ASCA, even though if it is in the higher side, you couldn't able to differentiate your fecal calprotectin inflammatory marker if it is on the higher side. Sometimes you'll always having a predominant doubt whether you are going to tackle a patient with Crohn's or you are going to tackle a patient with tuberculosis. So those kind of things, you can initiate the patient with tubercular regimen for first 1 to 2 months and serially redo the colonoscopy, reassess the patient, do a CT enterography, and if needed, endoscopic guidelines. All those things to see whether the patient is responding to the treatment or not. In case if the patient responds to the treatment, which means their treatment progression more in favor of tuberculosis rather than in favor of Crohn's, and at a treatment of the 6 months, 12 months duration, you need to have a serial follow and see whether the patient's consecutively improving, the findings, everything gone, and then you can able to diagnose the presentation well. So this is how you need to differentiate, but doesn't mean that if the patient showed initial response, even with the basic tubercular medications, doesn't mean the patient not having findings of Crohn's. So serial follow, nutrition, weight gain, anemia improvement, pain correction, all those things has to be involved when you're going to tackle this kind of presentation. So clinical assessment as a whole is very important to differentiate your inflammatory bowel disease from your tubercular lesion. This is what is very, very important as a clinician, as a physician, as a gastroenterologist. We should not forget that's how to recognize a patient with complexity. So all the GI problem doesn't mean the patient's having evidence of inflammatory bowel disease, and all the patient who are presenting to us in the background of bleeding PR doesn't mean the patient having IBD. So recognizing the patient as a whole is very, very important to tackle the presentation effectively. Basic pointers that what I may discuss, the symptoms will be predominantly your low GI pathology like kidney spells, bloody diarrhea, pain, and all those cramping stools, diarrheal events, pain and nausea, vomit in case of loss of appetite, fever, weight loss, significant weight loss, and all those things, psychological disturbances that might be predisposing, all those things will be there. But once a patient is having complexity in the anal canal, the patient may have stricturizing, penetrating. If you're going to look into the classification of Vienna in your Crohn's disease, so you're going to see your stricturizing, penetrating disease will be very complex. And this is how once a patient is going to develop with perianal fistula, that might be a complex fistula as per your Parkland's guideline. So at that point, as if you're, if the patient is having this kind of problems, so you should not be in a hurry to refer the patient for surgical intervention. Always see through the fistula, tackle the patient with basic antibiotic. In case if needed, place the patient on ceton, and then see through the patient and start the patient on biological support, either infliximab, adalimumab, or if you're planning to start on your vedolizumab or ustekinumab, what are the molecules you're going to treat, whether the patient's biological naive patients or if you've already been treated. All these pointers you need to see into account if you're going to tackle this kind of presentation. And There might be various precipitating factors, your infective pathology, in case, for example, your probiotic, and I mean, in case if your eubiosis is not going to get maintained and the dysbiosis is going to get taken in your GI tract, which should be predisposing to your inflammatory cascade, your T cell activation, which should be predisposing to multiple other alarming problems. Your antibiotic abuse, your diet fiber components, if not touched in a higher way, and your smoking. Smoking might be a protective in case of UC, but even then, the worsening events can be reported with the stress and NSAID. All those pointers you need to take into account as a precipitating factors, but we couldn't able to label this only one as a precipitating factor. So first, eliminating the precipitating factors, analyzing the patient properly will help you in clinching the clinical diagnosis effectively. Apart from that, there are four main pathophysiological factors. One is your immune response, your environmental triggers, your genetic susceptibility, your node mutation, your genetic susceptibility, all those things apart from your luminal microbial adjuvants as well as your antigens and adjuvants, all those major pathophysiological concept will be having a role to look into that. So the cytokine signaling, the chain of pathway will be most important thing when you're going to look into that. And so the central regulator of inflammation, the diverse range of signaling even within your cells, which will be predisposing to your cytokine cascade release, which will be predisposing to your necrosis as well as apoptotic of your mucosal trauma injury tends to get happen, which might be important for resistance to infection as well as your cancers to get developed. An integral part of the immune system, if it is going to get affected, that is the area which is being your chain of alpha activation, your cytokine pathway trigger will be predisposing to your inflammatory cascade, which tends to happen in your gut. And apart from that, so the main thing is your phagocyte, if it is going to stimulate, which will be predisposing by a neutrophilic attraction, the inflammatory cascade release, the fever and inflammation pathway is going to get triggered, which will be stimulating a phagocytosis. That's the area. And so what's going to happen? It's a pro-inflammatory cytokine, immune regulatory cytokine, your TNF alpha, so which will be predisposing to your leukocyte migration, your transcriptional activation, your apoptotic factors to get activated in your intestinal epithelial cells. And these things are being usually present in a higher concentration of serum, colon, and such, and in stool of such patients will be predisposing to inflammatory bowel disease. So how are you going to diagnose? The basic thing is clinical assessment. Look the patient as a whole, as I told you, and look for the pointers, what's the severity of the bleed, and based upon the criteria, whether the patient you're going to assess by Crohn's disease means you need to look for a Crohn's disease activity index. Apart from that, if you're going to look for your tool of weights for your ulcerative colitis means there are certain criteria to diagnose that, and always look for the clinical events, how far the severity of stool presentation, whether the patient is having toxic prodromes, whether the patient is having evidence of fever, leukocytosis, whether the patient ES or CRP, your calprotectin levels, all those pointers you need to take into account to diagnose whether the patient is going for worsening of events is there or not. And based upon categorize if the patient is tackling with ulcerative colitis restricted to the large intestine, see through that whether the patient is having involvement of the rectum alone, which means it's called your proctitis. If the left side of colon alone is involved, it means it's left side of colitis. If there is extending, if the lesion is extending to more than the middle of the colon, which means the transverse will be involved, which means the extensive colitis. The complete colon, even the right colon gets involved, which means the patient is going for pancolitis. So you need to categorize the patient. Then only you need to analyze which molecule you're going to use, what is the treatment you're going to decide, how are you going to manage a patient. This is the basics you should not forget. So analyzing, treating, looking into the cascades, tackling the inflammatory criteria, that's the point where you need to assess how are you going to manage a patient with inflammatory bowel disease. Either you're going to tackle on your Crohn's or your ulcerative colitis. There is no single criteria to diagnose your ulcerative or Crohn's, but diagnosis is based upon a constellation of your clinical, your endoscopic assessment, clinical picture, histopathological diagnosis, and your radiological features. For example, if the patient is having evidence of toxic megacolon, which means because of severe arterial disturbance and all those things, if the patient transverse colon damage, if it is going to be more than 5.5, then that might be the precipitating factor for you to go for a surgery. So you need to take the patient for surgical intervention. So these are all the GI emergencies you should not forget when you're going to manage a patient with inflammatory bowel disorders. So radiological criteria, all those points, whether ostral folds is intact, loss of ostrations, all these pointers to be taken into account when you're going to tackle a patient with inflammatory bowel disease. Apart from that, the medical history, as I told you, the symptomatology analysis is the first thing, and family history, any infections, any medication which is going to respond to this kind of presentation. And basic physical examination, you assess the patient, whether the patient is having hemodynamic stability, severity of GA bleed, whether the patient falls into mild bleed, moderate bleed, or severe GA bleed, massive hematochezia, massive output, severe anemia, which means the patient hemodynamics is not in a stable range, which means that the patient is going for severe colitis. So at that kind of presentation, you need to be very cautious whether the patient deserves intravenous steroids or whether the patient deserves emergency rescue molecule therapy. All those things you need to be cautious when you're going to dictate this kind of presentation. Apart from that, your lab parameters, your WBC, your CBC, as I discussed, your all the inflammatory cascade markers, your CRP, your ESR, anemic correct anemic evaluation, along with your fecal count protein levels and lactoferrin 2 to some extent can be taken into account to assess the severity. And this is what the basic scoring system, your Mayo scoring to us. See, if you're going to see, this might be a normal colon. And if you're going to see, just see the erythema, when compared to this colon, you're going to see there's a erythematous colon with vascularity. See, you can able to identify prominent vascular vessels here, but here the vascularity is almost gone and the mucus appears to be mildly friable. But here marked erythema, you can see marked erythema, which means the Mayo score is going in the range of 2 and the vascular pattern is completely gone and friable, looks like more friable, not a healthy mucosa. This is completely gone. Spontaneous bleeding. If you breach into with the colonoscopy, the patient will have bleed. The patient may have worsening of it. So this kind of patients, you need to be very cautious. When you're doing a colonoscopy, you need to be very cautious to prevent further penetration. And sometimes the patient may have evidence of perforation, other complication. So when you're performing for a patient with inflammatory bowel disease, always check the red signs. See through that whether you can able to sweep through the colonic mucosa comfortably through your colonoscopy. In case if you're having difficulty, make sure that not supposed to progress much. Assess the patient in the basic findings, whatever the best possible way you need to diagnose with minimal manipulation you need to do to prevent further complications and perforation. And if the patient is in toxic prodromes or the patient is a toxicity, at that point, if you're going to perform a colonoscopy, that itself will be predisposing to worsening of event. So first stabilize, assess, and then tackle and treat. That's very, very important for making a diagnosis. So this is for your Montreuil's classification. So this is what, so if the lesion is restricted for your Crohn's disease, if you're based upon your Montreuil's classification. So how they are going to label, so whether the patient is predominantly the terminal ileum is going to get involved, or if the restricted colon, if it is going to get involved in your L2, or ileocolonic mucosa by L3, upper GI will be in your L4, or upper GI and distal pathology will be in your L4, L3. So this is how, and structurizing, penetrating, and perianally penetrating lesion. This is how your Montreuil B category, all these pointers to be categorized into account, whether structure is there or not, whether structurizing and penetrating is there or not, all these pointers to be taken into account to classify your Montreuil's classification for your Crohn's. Assessing the severity, 5 pointers, mainly see the stools, the consistency, the abdominal pain, the well-being of the patient, extra GA, always in ulcerative colitis in GA, 8 to 4 examination is important. Starting from your head up to the lower region, you may have multiple presentation. Look into the eyes. Always the patient maintains to be anemic. The patient may be jaundice, which means the patient may have evidence of your coexisting primary sclerosing cholangitis in the background of your ulcerative colitis could be a possibility. That will be predisposing to biliary tract pathology. That will be predisposing for the patient to land up with evidence of jaundice. Or if the patient is having glossitis, anemia, severe correction, if the patient is having joint pains, arthritis, or if the patient is having back pains, ankylosing spondylitis, or if the patient is having evidence of autoimmune other disorders like your metabolic complications like calcium abnormalities, all those things, apart from your diabetes and other complication. Apart from if the patient is having ophthalmic complication like your uveitis, iritis, apart from if the patient is going to land up with evidence of any other renal complications, cardiac complications, there are so many extra GI and dermatological manifestations, your sweet syndrome, your pyoderma gangrenosum, all those pointers you need to look into the account when you're going to tackle your inflammatory bowel, because extra GA erythema nodes is very characteristic. Frequently will be seen the patient will be having predominant lesion which is affecting the shin of tibia. The painless usually will be painful. Not the nodular lesion will be there. That might be predisposing to worsening even that you need to be taken into account. And all these pointers when you're going to see tackle the patient effectively with the molecules, whatever is the best thing which is available, whether the patient is going to start on steroid, whether they're going to initiate the patient on steroid or along with the aminosalicylates, or if the patient is going to be on biologic support, all those things you need to analyze as a whole if you want to tackle this kind of presentation. And mass, your hematocrit, abdominal mass, any antidiarrheal abuse, or the patient's hematocrit, if it is going to be in the higher side, or if the patient's body weight, if it is not going to maintain, all these pointers to look into. And if the patient has a CDAI, if it is going to be more than 450, which means the patient is having severe Crohn's disease, that you need to consider when you're going to treat a patient. That's very, very important. So our target, you need to identify the disease first. You need to prevent the disease progression. You need to reduce the rate of hospitalization and reduce the surgical events and prevent the patient from relapsing of events. And first, we need to induce the remission to the patient. So induce the remission is very, very important. If you identify disease, so inducing the remission and maintaining maintenance of the remission and prevention of your relapse is very important to tackle a patient. That is how your treatment goals to be established when you're tackling a patient with inflammatory bowel disease. And the various line of molecules starting from your cascade, from your pyramid support. So mild presentation of your colitis, which means start from your aminosalicylates, various formulation, your topical preparation or your oral preparation or your enema or suppository. What are the things? If you are going to use your mesalazine, as a suppose, if you're going to use maximum dose of around 4.8 grams per day, start by around 2.4 to 4.8 grams per day of titration, and based upon the various molecules, the olsilazine, balsilazine, and all those things will be having a major adverse events of GI symptoms like diarrhea and other things. But your amino salts will be considering as a basic unit, but aminosalicylates alone not should be considered as a major entity to tackle a patient with your inflammatory bowel disease, even the patient continue to be in the mild to moderate range. Moderate criteria, if the patient fulfills, the patient may resource steroids. Oral steroids, prednisolone, start at the higher rate, 40 milligrams per day to maintain, along with slow tapering over a period of 8 weeks. So you can consider the patient, and while tapering, you can have the patient on azathioprine support, but when you're starting the patient with azathioprine, always assess the count as a whole, and that's very important to recognize the presentation. If the patient is not showing improvement, look for the TPMT levels or CG levels and all those things. That's out of discussion, but you should remember all those pointers, 6 GG levels, and this is how you can able to diagnose if the patient is responding to the treatment or not. And biologics, so once you're going to decide the patient on biologics, pediatric population, first presentation, severe events, permanent pancreatitis or worsening, stricturizing lesion, penetrating lesion, fistulizing lesion, then you can start the patient on biologic support. What are the biologics you're going to choose? First, identify whether the potency. So infliximab, a mouse-based, and adalimumab humanized. So all those things you need to consider. If you're planning for infliximab, 10 to 5 to 10 milligrams per kg, 5 mg per kg, and maintenance over the dose. And if you're planning to consider patient adalimumab support, start by 160 milligrams and slow tapering, approximately 40 milligrams, to maintain over a period of 1 to 2 years of duration. So that's how you need to titrate the patient with your biologics. That's very, very important. And if you're planning for your vedolizumab, even for vedolizumab, we have been trying for some patients showing reasonable response. And you're planning for even with your ustekinumab and other molecules nowadays, but the cost and other issues to be addressed. Apart from that, surgical intervention, the final pointer, if the patient not responding, fulminant colitis, if the patient doesn't show in the background of toxic megacolon and other complications, and changeovers and other things, then the patient may go for surgical intervention. That's very, very important to consider. And the basic one, as I discussed, your mesalamine, your sulfasalazine, olsilazine, or balsilazide. For your 5-ASA components, your steroids, already been discussed. Your budesonide at a rate of 9 milligrams per day. For moderate colitis, you can consider mild to moderate, but once the patient is going to land up with evidence of your severe colitis, usually the hepatic metabolism, first part metabolism will be less in case of your budesonide. So mild to moderate will be the preferred one rather than severe colitis. Always you need to go for your prednisolone if the patient is feasible. And immunomodulator therapy, your azathioprine, be careful when you're going to use, monitor the counts. And biologics has already been discussed, your inflexia orally, to whom you're going to use it. Before that, screen for the infections, your CMV, your Clostridium difficile, or if the tuberculosis, all these flare-ups, because we have been initiated a patient with with adalimumab support, followed by the patient at some patient may have worsening of your tuberculosis, and some patient may have evidence of worsening of iris, immune response reconstitution syndrome, all those things. The patient inflammatory syndrome, the patient may have worsening of even the patient landed with sepsis, septic shock, and the patient collapsed. We have personal experience. So why I'm pointing all those things? So you need to be cautious when you're going to use these kind of molecules. And Apart from that, vaccination the patient is very important. You need to give proper vaccination support and take care of your flu as well as your pneumococcal, meningococcal, all those vaccination guidelines you need to take into account before starting the patient on this kind of molecules, and serial follow-up or a duration of therapy. And usually, if you are going for any biologic support within a period of 8 to 12, within a period of 3 months, the patient should have a system in significant response of your clinical picture, and within a period of 6 months to 1 year, the patient should have a histological remission and other things. So how are you going to tackle the patient is very, very important when you're going to manage with this kind of presentation. So disease progression, frequent relapse will be characteristic in case of ulcerative colitis, and perennial disease, weight loss, structuralizing event, endoscopic criteria, severity will be very characteristic in case of your Crohn's. And briefly, few pointers about your adalimumab, which we frequently using in case of the severe conditions. And either for both the, even for your ulcerative colitis or for your Crohn's, you can consider this adalimumab, but it's humanized based. As I discussed, you start by 160 milligrams, taper at a rate of 40 milligrams while it's being available. Start by 160, taper at a dose of around 80, and maintain every fortnightly by 40 milligrams duration for a period of 1 to 2 years. Have a serial follow-up, see the inflammatory response has been coming down, and all those things has been taken into account. And we are having multiple experiences which this kind of patient, once you start the patient adalimumab or support, the patient will be having significant response. But serial monitoring is very important. Doesn't mean that one molecule is going to take him high. So serial monitoring means the nutrition, the growth, the development in pediatric age group, the psychological support, along with infection control, along with histological remission and histological healing, as well as clinical improvement. All those pointers has to be taken into account when you're going to manage with a molecule. Apart from that, briefly about this adalimumab is IgG1 antibody against TNF alpha, and multiple conditions are being used. Your psoriasis and juvenile idiopathic arthritis in moderate to severe Crohn's, as well as your ulcerative colitis, and already been discussed. So once you're going to start, this is a basic study with your in the background of Crohn's. What I'm mentioning that in 299 patients have been studied. So clinical response was defined as a reduction of more than 70 points from your baseline CDA score. So which means the patient tends to have a significant response once you're going to initiate based upon your charm trial what's being available. And apart from that, this is all the results being categorized. So adalimumab was found to be superior when compared to your placebo in maintenance of your remission in compared to your infliximab. So that's how the adverse events reporting with your infliximab slightly in the higher side when compared to your adalimumab support. And apart from in this paper, so what they were mentioning about, so the response, remission, mucosal healing, and steroid-free remission at week 14, 54 in biological naive patients. So response, remission, mucosal healing, and steroid-free, when compared all those things, the adalimumab will be slightly in the higher side over a period of steroid-free regimen. It's going to maintain for a duration, and that's how we are going to analyze the response. That's very, very important to look for the criteria. And factors influencing patient choice of a specific anti-TNF alpha stratified by a drug. So early administration, fear of syringes, time required for therapy, and all the things, all the pointers will be there. But adalimumab, the ease of it will be available in the pen formulation, like an insulin, small pen will be available, and all those things you can use it comfortably. Your adalimumab support, and so before concluding, what I would like to point out is there are multiple molecules being there when you're going to try anti-integrin, your genus kinase inhibitors, along with nowadays your tofacitinib and other things for your genus. And apart from that, your biologic mimics, your biosimilars being there well in the field, and new molecules like your uh, and apart from that, even with your nowadays your fecal microbiota transplantation has been there to consider, but still not proven much of entities. As for that, your probiotic supports some doctors been asking me the question about the probiotics. There are some role of probiotics, but so probiotics alone not proven to be beneficial effects like your lactobacillus, GG, and other things. Apart from that, basic molecule of steroids, your aminosalicylate, along with your biologic support and recognizing the patient, clinical response, see the pointers, diagnose the patient whether the patient having evidence of histological proven Crohn's or your evidence of ulcerative colitis or in the background of coexisting tuberculosis. All these pointers is necessary to tackle this presentation effectively. With this, I'm happy to rest my presentation, thanking you all for patient listening. And if there is any questions, I'm happy to answer over here. Thank you very much.
Thank you, sir. So now for Q&A, any questions from any doctors? No, sir, no question. And once again, thank you for joining with us in view of Cipla. We are thanking you, sir. Thank you,
Thank
sir.
you
Have a
very
nice day.
much, Team Cipla. And always recognize the patient early, tackle the patient effectively. True, because India nowadays becomes rampant with your inflammatory bowel disease. In every day, we are getting at least one patient of OP nowadays with your inflammatory bowel disease. So you need to be very cautious and recognize the patient in an early way. Otherwise, most of the time, the patient may lose the bowel and it's a chronic pathologic condition. The psychological support, everything is needed to overcome the presentation effectively, and cost constraints, everything has to be taken into account. And so many programs and guidelines are there. So all these pointers to be taken into account to manage this condition effectively, that too in India. Thank you very much.
Thank you, sir. Thank you so much.
Bye.